Hello and welcome to ID Talk, answers from an infectious diseases expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and leader at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. Well, this is the second week in September 2020, and as most of you know, our numbers in Arizona are trending down. That is fantastic news. There are decreasing numbers of patients hospitalized with COVID-19, increasing availability of ICU beds and ventilators, decreasing numbers of people presenting to be tested for COVID-19, and if you're measuring all the metrics carefully, you know, as do I, that many of our counties in Arizona and the school districts, importantly, are looking at metrics established by Governor Ducey and the Arizona Department of Health Services, which suggest that they have a low or moderate risk of disease. This means that the issues and questions of school reentry for in-person learning are first and foremost in the minds of all of our members, I'm sure, and first and foremost in the minds of all of our parents as well. So into this field then comes some confusion about the CDC's guidelines for testing. In fact, the news from the federal government, both from the FDA and the CDC, has been very interesting in terms of its backing and forthing over the last couple weeks. A specific question about well, I guess they're gone now, but the CDC's guidelines for not testing asymptomatic patients for COVID-19. That was a brief recommendation which was thankfully retracted quite rapidly after a significant international outcry against this. There was no science behind that. I leave it to you to consider what possible factors might have contributed to that recommendation. However, the CDC no longer recommends withholding testing of asymptomatic patients, and in fact, it's business as usual. So contact tracing, testing our patients, family members, etc., with a suspicion for COVID-19 or a possible exposure to COVID-19 is very much on the table. Fantastic. Similar news, the Food and Drug Administration and its take-backsies on initially refusing to and then granting and then considering to retract emergency authorization for use of convalescent plasma in treating patients with COVID-19. Again, there is a lot of data out there and studies ongoing, but there have been no conclusive studies with an appropriate evidence-based medicine approach which have demonstrated a positive benefit of convalescent plasma in treating those severely or critically ill patients with COVID-19. In fact, there have been several studies which showed no benefit whatsoever when controlled for other factors. There's one study actually related to Mayo Clinics, which is reportedly used to support the FDA's recommendation. However, that study was not designed specifically to demonstrate benefit. It was not certainly placebo controlled. It was not randomized. It's an observational study looking at outcomes of patients based on the timing with which they received their convalescent plasma. That study did show better impact for plasma being administered to patients in the first 3 days of illness versus being administered to patients 4 days or further into their illness. However, I will note significant selection bias errors present in that approach. And as the study authors themselves say, it's very difficult to be able to identify and then administer the intervention within the first 3 days. So it may not be a realistic application of the results of that study. Regardless, again, due to outcry and pushback from scientists across the country, there is no clear recommendation to use convalescent plasma in treating patients with COVID-19. To continue the confusion, another round of questions about what to do for the household contact of a person who is tested positive for COVID-19. Per the CDC, and you can find this recommendation on their website quite easily, the recommendation is to quarantine the household contact of a COVID-19 positive patient for 14 days, starting from the last day of, or I guess first day of the index patient's isolation. So there are several confusing factors in there. When does that clock start ticking? Well, in part it depends on the degree of contact between the exposed person and the COVID-19 positive person. Let us say that it is a household contact and that the COVID-19 person can successfully self-quarantine, meaning that no one else in the household is exposed to that person after day one. Well, in that situation, the 14 days of quarantine for the contacts starts on that day one. So when they no longer have exposure to the index patient. What about, as is far more likely, the household person who is COVID-19 positive and there is no ability for quarantine? Well, in that case, the CDC says that the quarantine for the contacts starts on the first day after the index patient has been removed from quarantine, meaning typically 10 days after initial diagnosis of COVID-19 with resolution of symptoms and at least 3 days being afebrile without taking antipyretics. This is very much a long time period within which exposure is expected to occur. And if you look at the science behind that, this doesn't make a huge amount of sense. In fact, we know, of course, that COVID-19 and the virus causing it, SARS coronavirus 2, is very contagious, with an attack rate within a household contact of anywhere from 18% up to even 40 or 50%. That's daily. So if, for example, one has exposure to an infected index patient at the home, likely exposure to all the contacts occurred prior to diagnosis of that person and certainly in the first 1 or 2 days after their diagnosis. Is there significant additional risk of exposure occurring in the next 8 or 10 days or so? Hard to say. However, following the CDC's guidelines, official quarantine of a contact of an infected person is 14 days after the last contact with that infected person. So that means a whole bunch of self-quarantine. That's the way the rules go. That's what we need to follow for right now. This is going to be very important, I think, as we now approach, or likely approach, formal school reentry, because there will be those kids living in a household in which there is a known patient, and they will be needing to continue their at-home virtual learning while going through that prolonged time period. Pluses and minuses to that, of course. I think we all know the social benefits, psychologic benefits of being in person in school, but we also know very much the health risks associated with that. So there's a whole bunch of risk versus benefit discussions which need to continue to occur. My hope, of course, is that we can all participate in those, bringing what evidence we have to a very clear and transparent conversation. Okay, let's look now to some testing based in the office. So a question asks, if a provider or staff person in the office has mild upper respiratory tract symptoms, such as sore throat, runny nose, congestion, etc., but without fever, and that person tests negative with a screening nasal antigen test, do they need to wait for PCR to confirm the negative in order to return to work? Well, this is a mostly difficult question to answer because there's always going to be that rare exception to the rule. But most often, the nasal antigen test, although it does have a false negative rate, is pretty good, even in comparison to the nasal PCR test, which itself is not 100% sensitive. So, if that staff person tests negative by antigen screen and is able to mask effectively, and that doesn't mean the mask below the nose, as we all know, but can mask effectively, practice and use proper PPE, then it is reasonable for that person to return to work without either performing or waiting for a negative PCR test to return to work. So what about those practices where PCR is unavailable? The same thing applies. The key here, though, is that that staff person or office worker has to be able to mask effectively. 99 times out of 100, the true prevention of transmission of SARS coronavirus 2 is via proper use of that mask. All other barriers add to the benefit, but certainly by themselves do not work. So yes, it's reasonable for an office worker to return to work with a negative antigen test, so long as they can mask effectively. Regarding mask versus face shield, so another question asks, parents are now starting to request letters from school allowing their child to wear a face shield instead of a face mask. Is this appropriate, and if so, for which children? We have some evidence to answer this question as well. So the short answer is no. A face shield does not replace wearing a face mask. There has been a very nicely performed study coming out of COVID screening or contact screening personnel that wore a face shield in addition to their mask and had a further statistically significant benefit in preventing transmission. However, that assumed that they were all wearing their face mask appropriately. So there is no case that I can think of in an evidence-based way in which a face shield or eye protection or anything like that would replace an appropriate wearing of the face mask. So I would not encourage our practices to offer such a letter or support. What about treatment options? Any new news on that? And specifically, are there treatment options we can consider in the outpatient setting for our COVID positive patients? The short answer is, again, no. In the ambulatory setting, most of the treatment interventions that we are coming across are showing benefit in terms of outcomes, time of hospitalization, prognosis, that sort of thing. They're all showing benefit only for those patients who meet criteria for severe or critical COVID-19 disease. These would be the patients who come in with an oxygen requirement, with concrete evidence of respiratory distress or failure. Those patients who actually require intubation ventilation or other critical care interventions. In those patients, the benefit of steroid treatments such as dexamethasone or long course methylprednisolone like Cymedrol, the benefit is clear. The benefit for remdesivir, the current antiviral agent which is being used with efficacy against SARS coronavirus 2, has been shown for a 5-day course, not a 10-day course. But again, the benefit was restricted to or only shown in those patients who were hospitalized and had severe disease. So there really is not much out there for the non-hospitalized, mildly ill or asymptomatic COVID-19 positive patient, which I guess fortunately will be the majority of our pediatric patients. What about the asthmatic, though, who comes in with wheezing and is COVID-19 positive? Yes, absolutely. They deserve their burst of prednisone, although studies have now shown that the 5-day burst of prednisone, 1 or 2 milligrams per kilogram per day, did not confer any improvement in the 28-day outcome indices compared to dexamethasone for 10 days, which did show a significant improvement. However, in this case, we'd be treating the asthmatic exacerbation, not so much the COVID-19 disease. So long story short, there was no data or evidence to support use of steroids or antivirals or any other interventions aimed at outpatient pediatric patients who are COVID-19 positive. Supportive care, indeed. Managing the symptoms, yes, indeed. But in terms of actually doing anything to affect the outcome of the viral disease itself, there's nothing out there, at least not so far. And then ending up is actually a shorter episode today, mostly because I think we're in a holding pattern waiting to see what happens with the state's epidemiology. So I've been asked multiple times in multiple venues, when or how can we see the end to this? I would love to say that Arizona and other parts of the United States could be successful in its social hygiene, i.e. social distancing, and its mask wearing strategies. But you know and I know that this is not realistic. In fact, in Tucson, we are now seeing a surge in cases from returning University of Arizona students who live off campus, despite quite robust interventions and a plan by Dr. Rich Carmona for the University of Arizona to address risk of transmission on campus. But there is nothing that seems to be able to modify behaviors outside of restrictive environments. So I sadly don't think that we'll be able to successfully do anything about our numbers in the country until or if preventative strategies come along, which brings us to the issues and the questions of vaccine. So yes, there are now multiple vaccine products out there. Six in the world, have now reached phase 3 trials. There are 4 in the United States, 2 of which are currently recruiting in Arizona. Both of these are the messenger RNA vaccine products, and those those studies have been recruiting quite successfully going forward. Other products out there are modified adenoviral vector vaccines, all of which should prove to be effective. They just need to demonstrate that. So the current thoughts, hopes, and fingers crossed approaches are that a successful vaccine or vaccines will be demonstrated later this fall, even as early as November, fingers crossed, and thus be ready for distribution with the initial hundreds of thousands of doses or million of doses, perhaps by December or January. I would really like to believe that's true. I would really like to believe that a vaccine will demonstrate that kind of efficacy. The next questions, of course, will be what about kids? And what about vaccine uptake? Who is going to agree to be vaccinated, especially with the messenger RNA vaccines, which is new technology? And nothing is known about long-term outcomes of that type of an approach to vaccine. The first question about kids, what about a pediatric indication? Well, as you probably know if you follow the media and or yourself have been recruited into one of the vaccine trials, they're recruiting age 18 and over. This is not unexpected. We all know that pediatric science lags behind adult science. And in terms of biggest return on investment, of course, unfortunately, the world's approach has been to try and immunize the adults who, in most cases, do have a higher risk of being the transmitters in the home environment. That may not be true for our middle schoolers and high schoolers who actually may be at higher risk of transmitting SARS coronavirus 2 as even older aged adults. Still some processing of the data from the South Korea study, which demonstrated that, and also the Italian study. But nevertheless, kids who are certainly in high school and early ages in college are going to have a degree of risk of transmitting the virus at home. Unfortunately, at least under age 18, there will not be evidence to support a pediatric indication, and I'm not aware of pediatric vaccine trials that are currently in progress right now. Perhaps and hopefully there will be a special either study created and or a special review done in a phase 1 or 2 pilot trial to try and get some evidence of pediatric both safety and efficacy. But to date, I've not seen that happening. So our best hope, of course, then is to support vaccine uptake among adults age 18 and older. And here the numbers are against us. Predictive modeling would suggest that for a vaccine that is 75% effective, we would need to immunize at least minimum 2/3 of the population. Well, we're already sunk because the last studies actually show that roughly 40% of Americans currently have said they would not be vaccinated. Now, horrible selective bias that study, and the truth remains to be told, but I think we all agree that the chances of successfully vaccinating 2/3 of the adult population in America are somewhat remote. That's assuming the vaccine is 75% effective. If, as the FDA has said, they accept a vaccine which is 50% effective, then we will need to vaccinate upwards of 90% of Americans for there to be herd immunity and protection for the rest, and especially including pediatrics. So that's where the hope lies. I think we have many, many, many miles to go before we can achieve that. But I would hope that we can all do our part in conversations in the office and even socially to support vaccine uptake if and or when it becomes available. And on a related note, as we approach influenza season, yes, I think we should also be strongly advocating for influenza vaccinations. Several reasons for that. Number one is, of course, to maintain or continue, hopefully, some herd immunity against influenza. Number two, to try and reduce onset of severe flu disease and thus reduce the burden on hospitals, our clinics, our emergency departments, which are just now recovering for the second or third time from being overburdened. How many more hits can the health infrastructure take? And especially a severe flu season might well be the kiss of death for some of our clinical sites. So trying to prevent the onset of severe flu disease is going to be critical. And then number three, in terms of a reason for suggesting supporting flu vaccination, is the fact that we don't know yet what the effect of a dual infection might be. We do know in pediatric evidence that the likelihood of dual viral infection so far has been rare. Most kids, when they come in with respiratory illness and are found to be COVID-19 positive or SARS coronavirus 2 positive, do not have other respiratory viruses. And that's been done using respiratory virus panels, so RSV, rhinovirus, parainfluenza, adenovirus, entero, etc. Those viruses have not been demonstrated yet. However, these tests have not been done in parts of the world that are currently experiencing an influenza annual epidemic. So nobody knows what the impact might be of SARS coronavirus 2 and influenza A or influenza B. I personally would not like to find out, so I would hope that, again, we're all doing our best to advocate for influenza vaccination as soon as vaccines are available, and hopefully as we continue to support that with ongoing outreach. So that is what I have to share with you this time. Again, please keep those questions coming. Thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to COVID, that's COVID, at azaap.org. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit azaap.org. Once again, thank you much. Have a great, peaceful rest of the week.